Good evening, everyone, and very warm welcome to all of you. I am Shifa Sheikh from DocPlexis. As we all know, DocPlexis is one of the India's most trusted and digital platform dedicated exclusively for doctors, focused on enabling continuous medical education and professional networking. So, dear users, we are excited to inform you that we have launched a new and updated version of DocPlexis application. You can now easily download the application from Google Play Store and App Store as well. So stay updated with the latest notification, important CME sessions, and learning opportunity all at to download the application, focused on enabling Google Play Store and App Store, and enjoy the happy learning process. So, dear users, I'm delighted to welcome you once again for today's very interesting session and series of webinars that we are conducting on a very important topic in pediatrics, that is pediatric gastroenterology session 3. So, as we all know, pediatric gastroenterology is dedicated to diagnosing and treating disorders for the gastrointestinal tract, liver, pancreas, and nutrition in infants, children, and adolescents as well. So, as a condition such as inflammatory bowel disease, functional gastrointestinal disorder, and pediatric liver disease become increasingly common, timely diagnosis and evidence-based care are crucial for better long-term outcomes. So, ongoing advance in diagnostic tools, biologic treatment, and multidisciplinary care can are continuously reshaping clinical practice and improving patient-centered management in pediatric populations. So for this very interesting webinar, it's my absolute pleasure to welcome our esteemed speaker for today's session, Dr. Ravindra S. Sonavne. Dr. Sonavne is a distinguished pediatrician and academician with expertise in pediatric pulmonology, nutrition, neonatology, and child health research. Trained at Sri Bahusaheb Higher Government Medical College Dhule and Government Medical College Nagpur. He currently serves as professor and head of the Department of Pediatrics at Vasantrao Medical College Hospital and Research Center, Nashik. Dr. Sonavne is actively involved in undergraduate and postgraduate medical education, clinical research, and academic mentorship, with research contribution in neonatal care, respiratory disorder, dengue, congenital heart disease screening, and pediatric nutrition. He has authored several national and international index publication and has presented research at prominent pediatric conferences. In addition to his academic work, he has held key leadership role within Indian Academy of Pediatricians, that is IAP, including president of IAP Nashik, and continues to contribute significantly to pediatric education, research, and patient care. So we are truly privileged to have him with us today to share his valuable insight on such a great and important topic. So without further delay, I would like to hand over this session to Dr. Ravindra. Over to you, sir.
Thank you, Shipa and DocPlexis, and also Sushant, technical person helping us. So this is now the third session, and in that we are in last two sessions we have discussed about the pediatric vomiting. So almost we have discussed 24 cases. So we will continue pediatric vomiting to a topic today also with case illustration, and we will try to finish all cases related with pediatric vomiting today, so that we can start in next session regarding the acute abdominal pain. There will be 30 cases of acute abdominal pain we will discuss in next session. So, should I share, Shipa?
Yes, sir.
Should I share?
Yes, you can, sir.
Just 1 minute. Okay. So, vomiting is a symptom and not diagnosis. So you have seen the Drishyam movie, almost three parts. So what you see is not the full story. You know, the Ajay Devgan, it is a South Indian uh, uh, version of this Hindi movie. And so omitting is the presenting clue and not the diagnosis. So what you see is not the full story. Now, Kahani movie, Vidya Malan was the actress. So hidden truth unfolds layer by layer. So behind omitting may lie diabetic ketoacidosis, then central nervous system tumor, or obstruction in gastrointestinal part. So hidden truth unfolds layer by layer. So now Andhadhun, that movie picturized on this Aishuman Khurrana and Tabu. So it was a suspense movie. So appearances deceive. So simple omitting may hide serious pathology. So now special 26. So highlighting the Akshay Kumar and Anupam Kher. It was related with the fake CBI raids. So needs smart investigation and not random action. So targeted testing beats shotgun labs. So that's very also you have to be targeted regarding the advice about the test to the patient. Now the baby, it was actually a patriotic movie and a thriller movie also, the action thriller movie, picturized on the Akshay Kumar. So it detect threat early. So red flags need rapid recognition. So what are the red flags? Bilious omitting, projectile omitting, neurological signs, dehydration signs, abdominal distension, and alter sensorial. So some of the famous quote. So picture अभी बाकी है मेरे दोस्त रजनीकांत पिक्चर में दिख रहे हैं but that movie was from this dialogue was from the Om Shanti Om Shah Rukh Khan and Deepika Padukone. So initial omitting is just the opening symptom. Picture abhi baki hai mere dost. So don't judge each day by harvest. That is the quote by this Wilson. So don't just diagnose it by first symptom alone. All that glitters is not gold. So similarly, not every playful child is benign. Risk comes from now knowing what you are doing. That's Warren Buffett is the master in the stock market in USA and all over the world. He's very famous. So empirical antiemetics without diagnosis are risky. And last, बड़े-बड़े देशों में छोटी-छोटी बातें होती रहती है, senorita. So this was a dialogue from the Shah Rukh Khan to the Kathir from Dil Wale Dulhaniya Le Jayenge. So even common presentation need systemic thinking. So this was just start. So to the case. So next case. So Dhruvika Patil, 4 months old female. So one toxic chemical failure causes a rapid catastrophic chain reaction. So that was the movie Bollywood analogs that Kante when the Amitabh Bachchan was one of the hero. So how the patient presented? Yesterday, patient was feeling poorly. Major clue was similar prior unexplained illness episode. That episode worsened with the fasting or infection, and then patient had a recurrent repeated vomiting began just 12 hours back, and 8 hours back patient presented with severe lethargy and poor responsiveness, and in last 6 hours patient developed fast breathing or tachypnea, and in last 2 hours patient developed abnormal jerky movements. So first start was the was feeding poorly and worsened with fasting and infection, then recurrent vomiting, then severe lethargy, then tachypnea, then abnormal jerky movement. So almost GIT system, then respiratory system, and CNS system is also involved. And there was a history of worsening with the fasting. So pathophysiology, metabolic pathway defect. So toxic organic acids accumulates. that causes severe metabolic acidosis, brain toxicity, and energy failure. So what was the classical clue? Recurrent infant metabolic crisis, lethargy, acidosis, and seizure. So key differentials are organic acidemia, mainly acidosis crisis. Then sepsis can be the differential diagnosis, but infection pattern is different, and urea cycle defect, mainly hyperammonemia is there. So what the emergency panel, what was the diagnostic script? So glucose, immediate point of care check, arterial blood gas, critical. Look for mainly profound metabolic acidosis. Now, ammonia and ketones were to see that will give the clues that are the mainly metabolic clues. Ammonia may be elevated. And what is the spatial metabolic test or definitive test is organic acid profile. So stabilize airway, breathing, circulation, stop catabolism, urgently provide IV calories or glucose, urgent specialist opinion is required, metabolic management is required, and mainly isolation is required. So what is the sensor warning? So what are the red flags which will be very hyper urgent? Seizure, coma, severe metabolic acidosis, shock, and rapid neurological deterioration. So this was the this organic acid summary. Acid cascade disruption, normal energy pathway, but metabolic defect caused toxic organic acids to accumulate. That was encephalopathy and energy crisis. So acute decomposition pathway, after feeding, there is a recurrent vomiting, there is lethargy, CNS depression, then followed by tachypnea that was indicative of too small breathing and jerky movements and seizures. Emergency alert was in this patient, seizure, coma, severe acidosis, and shock. So the bedside screening was done, blood glucose, ABG, that pH was reduced, and the ketones, and there was a metabolic acidosis, ketones and ammonia was high, and investigation of choice was this GCMS, that was a definitely in urine mainly, so definitive this profiling, and this MSSR blood acid carnitine levels to diagnose this organic acidity. So vomiting plus alter sensorium plus wide anion gap ketones, like metabolic acidosis, think organic acidemia. So this is okay. So, so the Vedant Joshi, 6 years old male, status was uncomfortable, vital stables. So patient was having long-standing constipation, long-standing hard stools, painful defecation, withholding behavior, and since past week that constipation is worsened, and since last 5 days, no stool for 5 days, and patient is having bloating and crampy pain, and today patient has started vomiting and food containing, and danger if there is a bilious vomiting occur. So what are the classical cues? Constipation history, withholding, bloating, abdominal pain, and vomiting. And clinical examination was suggestive of the abdominal distension, fecal mass, fecal mass was palpable, then mild diffuse tenderness. Okay, so so this was a pathology roadblock. Large fecal burden creates an unpassable barrier, and the congestion forces contains upward, triggering nausea and vomiting. And so this was the system reversal. And what is the upstream backup? Intestinal traffic backup causing severe distension. You can see that there is already first barrier, and then upstream backup, intestinal traffic backs up, causing severe distension, and then congestion forces content upward, triggering nausea and vomiting. So, what is the this constipation mainly chronic stool history? In obstruction, there will be more acute and severe. In gastroenteritis, there will be diarrhea. So, history is very critical. Chronic stool history, painful defecation, withholding behavior. Exam, abdominal fecal loading clues, abdominal distension, fecal mass possible, mild tenderness. X-ray, selected uncertain cases, so it is useful. Confirm large fecal burden if doubt exists. And the red flag workup is concerning for obstruction if major signs present like a bilious vomiting, abdominal distension, persistent vomiting, or then investigate immediate blockage. So what are the red flag? Bilious vomiting, severe distinction, no flatus, peritonitis, systemic toxicity. So action plan after this impactation that will immediate relief, then hydration, crucial support, maintenance bowel plan that will prevent recurrence, then behavioral therapy, mainly toilet training habits to be cultivated, and diet counseling like the fiber, excessive fiber, excess huge intake. Um, so vomiting plus bloating and no stool passing history, things of fecal impactation exclude obstruction. So now vomiting is a channel on three pathways of acuity. So we'll go one by one. The happy spitter phenotype we will discuss. Range Patwardhan, 3 months old male. Vitals were normal, hydration were normal, growth was appropriate, and the chief complaint was a frequent speaks of the feed since 1 month. This is a 3 month male child. Just remember Chota baby. So chief complaint that was a frequent speak up of the feed. So what was the history of progressive illness and pattern analysis? Volume was small quantity. There was no effort. It was effortless, but no forceful or projectile vomiting. Okay, that that really happened in CNS or some obstruction therapy. The timing was shortly after feeding. Composition, no bile, no bile. Means, that rules out the obstruction most of the time, and no blood. So that rule out inflammatory bowel disease or inflammation. In systemic signs, no fever, no respiratory distress. So other system was not one. So just remember physiological gastroesophageal reflux, that is GR. The anatomical reality is that immature low esophageal sphincter plus 100% liquid diet, mainly breastfeeding mother, there's a milk, mother's milk, and the baby supine position that physiology cause effortless regurgitation. This is a physiological norm that will improve with the age. So the verges is the and supine position, immature alias and liquid diet. So leaky baby bottle. A small harmless leak, bottle still works perfectly, baby is still absorbing nutrients and growing. So, so differential clues versus gastroesophageal reflux disease. Um, uh, in GR, there is no distress or feeding complication. In GRD, respiratory distress can occur due to aspiration or feeding complication may occur. Now, in pyloric stenosis, there will be projectile vomiting, but here the normal GR, no projectile. Then CMP, cow's milk protein energy, there will be failure to thrive or growth stunted and poor feeding. So in this physiological gastroesophageal, there will be normal growth and no poor feeding. So what is the difference between true vomiting versus regurgitation? I have explained by the analogy. So you have seen this movie mainly for the young students, especially going in the college, they're staying in the hostels. Chichore is the fun Charles versus the actual emergency. Two images are there. In first image, all are injured, and in second, there is a projectile vomiting. That is the pathological vomiting. Now, in Three Idiots, just see this Fahrenheit confusion. Amir Khan says this Fahrenheit confusion. So these parents in Madhun get confused. So parents generally misuse these terms like vomiting and regurgitation constantly. Now, Hera Fairy, this miscommunication creates a child. You know that Parish Rawal, Akshay Kumar, and the Sunil Shetty, Babu Rao Kastale. So, in that, you see the miscommunication, how this create a chaos. So, wrong symptom description that can lead to wrong diagnosis. That's why That's why difference between true vomiting and regurgitation is very important. Ask the right question. So PK, forceful or effortless. Okay, the speaking, Amir Khan was actor. Then Munna by MBBS, Sanjay Dutt, right? Become a MBBS doctor. So clinical observation matters. Okay, so some of the famous quote, Jadoo ki Jappi from the this Munnabai MBBS. Not every spit up need medication. So just counseling Jadoo ki Jappi, that is enough. Then Osler, what he says, listen to the patient. He is telling you the diagnosis. You listen. A good speaker is the good listener. गलती से mistake हो गया. So calling reflux, this regurgitation, omitting. So reflux or omitting may differentiate. So Einstein, if you can't explain it simply, you don't understand it enough. So now on the last is baby is smiling, all is well. So happy spitter usually okay. So all is well, the dialogue from the Three Idiot movie, feature of the Ami Khan, John Madhavan, and the Norman Joshi. So vomiting is forceful from the stomach, may be projectile, associated with nausea, can be pathological. Regurgitation is effortless when esophagus spits up or dribbles, no nausea, usually benign. So remember, not all that comes is vomiting. Listen, observe, ask the right question, diagnose the cause. So this was the same red flags, projectile vomiting, bilious vomiting, meta-analysis, poor weight gain, field episode, respiratory symptoms. So reassurance is very important. Clinical diagnosis, no investigation needed. Avoid overfeeding the infant. Ensure frequent burping after the feed. And the safe sleeping and supine. Do not use wedges. So this is very important. So usually don't need this protein pump inhibitors like omeprazole, lansoprazole, rabeprazole. Okay. So this was a physiological gastroesophageal. I have made one this point, some of the points. So the pathological transition driven by the dysmotility, delayed emptying, esophageal clearance, delinking reflux from respiratory symptom, empirical acid suppression rarely resolves independent cough and wheeze. Then the old diagnosis. So it's very important. GR and GRD should not be. It's the rare cause GRD. So routine acid suppression not recommended. CMP prevalence up to 40% of GR cause cases at tertiary centers. Elimination diet trial before medical therapy we can use. Then the this pH impedance can do this that detects acidic and non-acidic reflux common in infants. Then 4 to 8 weeks empiric window for older kids if there is a GRD. Yeah, so taper if no improvement, that is called as refractory GRD, where this treatment we will give in the GRD, not GER. And PPI is no more effective than placebo for unexplained crying in less than 12 months. So risk of adverse effects are using infant. So strict adverse profile, increased risk of pneumonia, clostridium, typically GIT infections, hypomagnesemia, vitamin B12, malabsorption. Now, positions advice, always supine sleep, because in prone position, there are chances of sudden infant death syndrome. So sudden infant death syndrome risk overrules prone or left lateral position, very important. Now the field thickening standardization, reduce visible spitting, monitor calorie density, excess gain, avoid standard thickeners in the prenatal infants because that can cause necrotizing enterocolitis. And what are the red flags demanding immediate action? Bilious vomiting, forceful projectile vomiting, and onset after 6 months. Now, the Sandifer syndrome, what is that? Paroxysmal dystonic movements, back arching, and head turning protect airway from acid esophagitis. It mimic of seizures. So think of GRD, it's the Sandifer syndrome, like paroxysmal dystonic movements or back arching or head turning is present. So we can see this leaky baby bottle, that is GR, that is mainly due to immature esophageal sphincter, and it has a normal weight gain and growth. Versus CMP, cow's milk protein energy, there will be no normal growth. So now next case, So Prisa Naidu, 9 months female, presented with the vomiting and fever since 1 day, poor bleeding since 12 hours, lethargy since 8 hours, and reduced urine output since 6 hours. So vomiting, fever, poor feeding, lethargy, reduced urine output. So what was the history of present illness? Parents suspected a stomach infection, but babies become less responsive. So major red flag, no obvious diarrhea. What were the vitals? Tachycardia, fever, possible hypotension, and perfusion. So all extremities there, delayed capillary refill time, and sensorium there was a reduced responsiveness, and the appearance was a toxic. So you have seen the Uri movie, that is a patriotic movie, the surgical strike. Um, After Uri attack, the surgical strike was followed in Pakistan. So that was so what is the pathophysiology of sepsis-induced vomiting? So systemic infection cause inflammatory storms that raise the cytokines, poor perfusion and organ dysfunction occurs that cause neurological triggering of the vomiting center. So enemy is everywhere. The whole nation system is unstable, not just one city, that is the organ. So compromised perfusion, just remember. So how differential clues versus gastroenteritis? In gastroenteritis, there will be diarrhea and there will be typical pattern and there will be this profound systemic instability. Then meningitis, it requires CNS dominant signs like neck stiffness or sometimes curving sign, Buchanski sign. Okay, headache in the older childs. Mm, then the decay, that is diabetic acidosis, it requires metabolic clues like metabolic acidosis. So this is the infant sepsis escalation clinical protocol. We already discussed how this neurovagal axis triggers the medullary vomiting center that is situated in area prostima. So result is isolated early warning, severe vomiting without diarrhea. So it is a major systemic red flag. Altersensorium lethargy indicates poor or brain perfusion. Poor motor skill, the patient is shocked. Watch for delayed capillary refill time more than 2 seconds or flash refill that is less than 1 second. Then oliguria fewer than 4 weight diapers or less than 1 ml per kg per hour. So the golden hour mandate, every hour of delay in empirical broad spectrum IV antibiotics linearly increases infant mortality. So do not delay. Pair blood cultures draw immediately, ideally before antibiotics. Inflammatory markers like a CBC, CRP, procalcitonin to be done. Metabolic organ panels to be done, like a renal function test, serum electrolytes. Lumbar puncture performed once hemodynamically, patient is stabilized. To rule out meningitis. So step 1, stabilize airway, breathing, circulation, and check the blood glucose. If the patient is hypoglycemic, we administer 2 ml per kg per 10% dextrose by IV or intravenously. Then balanced fluid boluses, you can give 10 to 20 ml per kg of lactate over the 5 to 10 minutes. Reassess liver status, listen for rails after each bolus because it can cause pulmonary edema or fluid overload. So now fluid refractory pivot, if shock persists after 40 ml per kg of fluid, more than 40 ml per kg of fluid, stop boluses, immediately deploy inotropes like epinephrine or epinephrine, and the patient needs PIC transition, fast track to the PIC for the continuous invasive hemodynamic monitoring and advanced life support. So this was mainly related with the sepsis. It is a similar thing. So this again, I will not repeat this. Same is that. So the biggest danger is the septic shock, and most time sensitive treatment is antibiotic. What are the red flags was present? Shock, altersensorium, oliguria, respiratory distress, and seizure. So now next case. Arno Bendre, 13 years old male, presented with the sudden abdominal pain since 4 hours, vomiting since 3 hours, restlessness since 3 hours, and severe groin pain revealed upon detailed questioning since 4 hours. So sudden abdominal pain, vomiting, restlessness, and severe pain. So what was the history of present illness? Initially presented to be stomach problem due to severe lower abdomen and repeated vomiting. Critical clues: no diarrhea, no fever, and sudden onset. Sometimes no trauma history. And what are the vitals? Patient was having tachycardia, sweating, and the appearance was distress, restless, inability to sit comfortably. So this was the autonomic vagal reflex case. So what was that? This was the testicular torsion. What is the mechanism of action? Testis twist around spermatic cord, and that caused arterial blood supply to be compromised, and that was profound ischemic pain that radiates upward, and that was severe autonomic vagal response that triggers persistent vomiting. So analogy is like a twisted cable, power cable twist, blood electricity supply stops, and organ device dies without rapid intervention. So now, what are the differential clues? Appendicitis has right lower quadrant progression, torsion has a squattal finding, and this okay, and the gastroenteritis. There is no diet. The torsion there was no diet. Gastroenteritis was also ruled out. So the examiner tract, abdominal pain plus vomiting equivalent to appendicitis, but lower abdominal tenderness can completely mislead you. Always examine the testes. In boys presenting with abdominal pain and vomiting, look for high riding testes, tenderness, swelling, and or abnormal lie. High riding testes, tenderness, swelling, or abnormal lie. So clinical recognition, do not delay. Okay, so very important. Urgent hours matter. Urgent review, that is time equivalent to testes, and Doppler ultrasound only if diagnosis is uncertain and it was absolutely no delay in the care, shows reduced flow. Then emergency surgery is detorsion or definitive fixation. Usually includes contralateral fixation, but most of the time patient comes with the complete necrosis of one spot or the gangrene also. So sometimes you have to remove hemiorchidectomy also. So it is testicular torsion diagnosis is very important. So this is the difference between the physiological GR, pediatric sepsis, and testicular torsion. Physiological GR, there are fluid dynamics of plumbing section mechanism. Pediatric sepsis, systemic inflammation is strong, and testicular torsion is a ischemic autonomic reflux. In physiological GR, patient will be happy, thriving, and active. In sepsis, there will be he or she will be toxic, lethargic, unresponsiveness. In testicular torsion, patient will be agonized, restless, and distressed. So vomiting quantity in physiological GR is small, effortless, picked up. In pediatric sepsis, they may be repeated, associated with fever. In testicular torsion, they will be repeated vomiting, driven by sudden severe cold. So what are the hidden clue in physiological GR? Normal weight gain, normal growth. In pediatric sepsis, poor perfusion or delayed capillary refill time. In testicular torsion, there will be scrotal abnormality in high riding testes. So the primary action is in the physiological, mainly reassurance and clinical exam. In pediatric sepsis, mainly ABCs and all this sepsis screening and broad spectrum antibiotic. In testicular torsion, urgent genital exam and surgical review. Time sensitivity physiological none improves with the age. Pediatric sepsis is mean patient was having an septic shock risk, and in this hours, testicular torsion in hours, the testis can be damaged. So this was said. Now we'll move to the next case. So the initial assumption was the parents and clinical alike often assume recurrent vomiting is the acidity, gastritis, or gastroenteritis. But what is the neurological alarm? When the vomiting is uncoupled from the diarrhea and paired with the progressive neurological decline, the primary pathology lies about the neck. So diagnostician must look up and not down when there is no diarrhea or other GIT symptoms with recurrent vomiting. Okay. So the patient, Athar Desai, 8 years old male, presented with a chest complaints, early vomiting, early morning vomiting, headache, unsteady gait. Now, since 6 weeks ago, patient had occasional morning vomiting. Now, 5 weeks ago, patient presented with a morning headache, beginning weeks with the morning morning headache begins, and patient wake with the headache, vomiting soon after waking brings temporary relief. So now, 2 to 3 weeks ago, there was an unsteady way of walking, that is also called ataxia, clumsiness, and difficulty climbing stair. And now patient was having visual blurring, school performance was dropped, and the patient was severely irritable. So 6 weeks ago, patient suspected acidity. Okay, so generally, in looking child, water shows potential rise, intracranial pressure changes, and the cranial nerve, there was six nerve palsy was suspected, and the motor or cerebral ataxic gait, abnormal coordination, mother reports occasional healthy, that is suggestive that was giving critical posterior fossa involving flu, and the fundoscopy was done, and a couple of neurons present. So abdominal examination completely normal, no signs of illness, and so the hidden control room bomb was the posterior fossa tumor. So, like the mastermind in special 26, the visible Charles is a merely symptom of the hidden mastermind, that is the tumor. So, key takeaway: tumor blocks is a flow, raise ICP, compress the brainstem, omitic center is directly stimulated. So, this was the this time one slide. Early morning vomiting. Why did early morning vomiting occur? Because peak CSF pressure in supine position, and that affects brainstem omiting center. So CSF pressure birth time. Now omiting brings relief pattern. Why that occur? Hyperventilation temporarily lowers PCO2, causing cerebral vasoconstriction and brief drop in intracranial pressure. And why this patient was presented with ataxic gait and motor coordination deficit? So cerebral compression or invasion was present. Cranial nerve 6 abducent was also involved. There was a palsy. So what was the cause? Traction on the long intracranial nerve cords leading to diplopia. And papilloedema on fundoscopy is due to mainly, and that's an absolute sign of elevated ICP. Optic this is present. So obstructive hydrocephalus blocking normal CSF flow, and the brainstem omiting center stimulation we already discussed, direct compression, and this due to large tumor, that is in area persona. So look up and not down exam, persistent vomiting uncoupled from GIT symptom, think about the next, stop managing as a gastritis. Absolute contraindication of now what is the investigation child? MRI brain with contrast, that is the gold standard, high resolution that gives anatomical details and tissue characteristics. CT head may be done in emergency alternative if MRI is not available. Rapid rule out of acute hydrocephalus or bleeding. So now this is standard treatment protocol. Emergent intracranial tension pressure stabilization. That is medical mitigation, corticosteroid, dexamethasone we can use, osmotic therapy, mannitol we can use, or 3% normal saline we can use. Positioning the head of the bed can be elevated to 30-degree. And so what is the surgical management? External ventricular drain, that is EVD, or endoscopic third ventricular stomy to safely lower intracranial pressure before tumor removal. And definitive surgical resection is the definitive management, that is craniotomy incision, biopsy dictates secondary oncological management, chemo and radiation therapy may be given later on after diagnosis. So absolute contraindication of lumbar puncture is the fatal brain herniation through foramen magnum before neuroimaging. So this was a slide about the posterior fossa tumor in with the old male. Okay, so we already discussed. So neurological examination, fundoscopy, MRI, and CT. We have reduced progressive morning vomiting plus neuroscience. You should think of brain tumor until excluded. Now, next case, ROE Mehra, 8 months old female, recurrent vomiting, irritability, increasing head size. So 1 month ago, there was increasing head size. Family initially attributed to normal growth, but 1 to 2 weeks ago, patient had irritability, which was increased, and that 4 million begins. And 10 days ago, patient had recurrent vomiting started, and the 5 days ago, baby become less playful and increasing severely. Now, the contest banner is no diarrhea, no clear KIT illness. Now, cranial vault was there was a macrocephaly, that means increased head circumference. Anterior fontanelle was a tense and bulging. Prominent scalp are seen, and after on examination, neurological CNS examination, variable tone, developmental slowing or regression seen, and alter vitals indicative of the raised ISP, that is bradycardia, hypertension, irregular, often irregular pupils, and the alter respiration. So now the ocular clue, the sun setting sign, the classical infant eye sign of raised ICP force in the eyes downwards. So vomiting plus increasing head side plus bulging fontanelle, you think have to think hydrocephalus until excluded. So this is just overflowing water tank. What is that? So like the closed system in our fluid keeps rising, pressure builds, alarm triggers the vomiting. So CSF accumulation, ventricular enlargement, raised ICP forces unfused infant cranial bones apart, and that was vomiting. So pediatric hydrocephalus, macrocephaly, you can see rapidly increasing head circumference, prominent scalp weight, bulging anterior fontanelle, irritability, sunsetting sign, persistent vomiting, lethargy, developmental degradation, and essential investigation, neuroexam, neuroimaging, fundoscopy, MRI brain, or cranial ultrasound, or CT scan is used only. And so the primary treatment was a surgical intervention, ventricular peritoneal shunt, that system flew from brain ventricle down to the axis for the abdominal cavity for the absorption, and endoscopic third ventricular stomy, often paired with the choroid plexus cauterization. So management consideration, surgical removal of moss mainly for the obstructive cases, and the follow-up lifelong monitoring is required for shunt functionality, including periodic clinical visit, neurological exam, imaging to check the complications, infection, and malfunction. So head circumference, neuroexam, cranial ultrasound, definitive imaging. So unlike the older children, the open fontanelle provides unique acoustic window for immediate non-invasive bedside ultrasound imaging. So these are the two cases that Arohi, where there was an unfused cranial suture that expanded skull, and that was a microcephaly, bulging fontanelle, and sunsetting sign. Now in the other case, there was a fused cranial suture, so there was no primary compression. It was a fixed volume box, and that presented the papilloedema, focal deficit, like ataxia, cranial palsy, progressive morning headache. So the common denominator is vomiting. The age dictates the physical signs. So, these are the differences between brain tumor and hydrocephalus. So updated management we already discussed. So very important. So neurovomiting red flag dashboard, when to abort the GIT diagnosis and image the brain immediately. So early morning projectile vomiting with progressive headache, papilloedema, sunsetting eyes or sudden visual blurring, onset of gait disturbances, ataxia or clumsiness, tense bulging fontanelle or rapid macrocephaly infant, and altered sensory unexplained severe because seizure. So these are the neurovomiting red flags. So treating as a gastritis repeatedly without through neurological examination is a dangerous mistake. So now we go for the next case. Sunny Bharadwaj, 12 years old female, presented with a recurrent headache, vomiting during attack, light sensitivity at photophobia in 6 months. School absence is since 3 months. And what are the clue alerts? The triggers of sleep deprivation, stress, skip meals, and the family history. Mother was also having history of the migraine. So a sudden systemic short circuit is the control center. So that electric storm, how migraine triggers the vomiting. So triggers stress, sleep, food, that was neurovascular dysfunction, that was brain hypersensitivity, and that was nausea and vomiting pathways to be activated. So just as a sudden electric storm disrupts the city's central control system in the Krishna 3 movie, this migraine act as a neurovascular short circuit. So what are the classical clues of migraine? Episodic headache, vomiting exclusively during attack, photophobia, that is distressing light avoidance, positive family history, normal neuroexam between attack. And what are the red flags? Where we're doing this immediately, progressive headache, morning worsening, focal neurological deficit, papilloedema, and alter consciousness. So what are the differential diagnoses? Brain tumor is in that there will be progressive neuroscience. In this cyclic vomiting syndrome, there will be vomiting will be dominant feature. Then in meningitis, there will be the signs of symptoms and signs of infections. So what is the guidelines for the managing pediatric migraine? So classical migraine presentation we already seen, and red flags are also we have seen. And what the investigation? It is a critical clinical tool is the neurological examination. So that is very important. MRI, CT scan routinely, not recommended for normal neuro examination. Imaging reserved strictly for the red flag symptoms to rule out secondary pathology like a mass and meningitis. So you know this approach to treatment and updated guidelines, acute attack care and trigger management. So there should be dark room and their bed should be quiet bed. The hydration there should be proper. Then sleep it should be adequate. Then your lifestyle you have to follow routines, diet, etc. Exercise. Then consistent meal. Then exercise is very important. Then second is acute analgesia. The first line is the NSAIDs. You can use ibuprofen, naproxen, or even paracetamol. Then triptans, when in initial analgesic forms, FDA approved, we can use rizatriptan. That is mainly above the age of 6 years. This is the FDA approved for adolescent 12 plus year, and for adolescent more than 12 years, sumatriptan or zolmitriptan or almotriptan can be used. In severe attack, where to do the investigations in adult parental guidelines recommended, first line is IV prochlorperazine, and second line is IV metoprolol, especially for the this omit. Okay, so these are the main IV prochlorperazine or IV metoprolol, which is mainly for as an anti-emetic. Okay, now prophylaxis resources, nutritional, that is low risk, dividend-based, magnesium riboflavin containing magnesium riboflavin, vitamin B12 or coenzyme Q10, and the pharmacological options that are mainly topiramate that reduces headache days, and the amitriptyline or fumarate can be considered based on clinical profile. So emerging therapies are CGRP monoclonal antibody, GPANs, that are actively evaluated and management of the pediatric migraine. So, you know, we already discussed this dark white room, hydration, analgesia, antiemetic, triggering neuropathy, and prophylaxis. So, do we need imaging for every pediatric migraine? No. Mostly it is a clinical diagnosis, image only if red flags are present. How relevant is the family history? Highly relevant, very common suppletive leave. So, electrostorm, brainstorm strikes, light hurts, system omits. So, now next is Ishan Trivedi, 15 years old male, with a chip complaint of recurrent vomiting, early satiety, pain after meal, weight loss history since 2 months, upper abdominal fullness since 2 weeks. So weight loss was the critical clue, recent significant weight loss following prolonged illness, and the history of present illness, vomiting occur after meal, mainly food containing, sometimes villus, epigastric fullness and pain is present. So key teaching clue was the symptom improving certain physical position. So positional relief symptom improving certain position like a leaning forward or side lying. Okay, so you can see the highest flywheel crush. That is the mechanism of the superior mesenteric artery syndrome. So this is superior mesenteric artery syndrome. So when the anatomical cushion disappears, structural strap closes. So like a vehicle trapped in a massive gridlock under low highway flyover, the digestive system gets completely jammed between two major structures. So pathophysiological time, you can see aorta, you can see that superior mesenteric artery, and we can see the duodenum. So in the duodenum and this SMA, there is this fat cushion was missing due to so what was the that analogy? Rapid weight loss, depletion of mesenteric fat cushion, that was aorta and superior mesenteric angle that narrowed, and duodenum is mechanically compressed. So clinical suspension. So unlike a migraine, structure trap requires anatomical visualization. So key starting point was a thinking and post-meal vomiting. The second basic lab assess electrolytes and dehydration severity. Then upper GIT contrast may reveal the mechanical obstruction pattern, and CT angiography and advanced imaging provides definitive diagnostic anatomy of these superior mesenteric artery angle. So what are the red flags? Severe dehydration, persistent vomiting, inability to tolerate feeds, and major weight loss. Now, what are the differential diagnosis? Gastroparesis. This is the gastroparesis is the only motility issue. Then gastric gastric outlet obstruction. There is a problem in structural outlet. In eating disorder is a separate contest. So this was a superior mesenteric syndrome just highlight. The adolescent, or there is a recurrent post-pneumatic early pain, upper abdominal fullness, and positional cues. So insofine there is worsening of symptom in leaning forward mainly to less than 25, improve symptoms, and knee chest position also improve symptom, and left lateral detriment position also improve. So you see angle less than 22 in SMA and duodenum, and this compressed third part of the duodenum. You can see that a highway plywood brush. And important investigation, we know basic labs, neural dehydration and electrolytes, duodenal dilation sequence 2, and the CT angiography, CT with oral contrast is the gold standard. So approach to the treatment, mainly conservative medical management. First line goal is aggressive weight gain, multiple small high calorie feeds, enteral feeding via transphyloric, enteral feeding via this nasogenital tube. Also, we can give total parenteral nutrition if needed. Gastric decompression can be done by inserting nasogastric tube, and post-meal posture therapy, mainly left lateral or prone position, to be advised. So actively pursue conservative treatment for at least 6 weeks before surgery in child. So what is surgical intervention? It is done in the refractory cases. Procedure of choice is the laparoscopic duodenectomy that bypasses the compressed segment, and success rate is almost 80 to 100. So in that, the red flag was severe dehydration, persistent vomiting, major weight loss, and complete inability to tolerate feed. So this was a very interesting case of a superior mesenteric artery syndrome. So decompression, nutritional rehabilitation, positional strategies, and surgery. So what is the key risk factor for SMA syndrome? Rapid, significant weight loss, which depletes the mesenteric fat pair. Why does present position provide relief? Because altering posture physically changes the angle of vascular compression on the gut. So memory cook is the flyover crush, road trapped under flyover, traffic blockage system backs up. The next case we will go now. Okay, so the Krish Malpani, 13 years old male, recurrent vomiting, nausea, upper abdominal burning pain since 2 weeks, recurrent vomiting, nausea since 10 days, reduced appetite since 1 week, history of present epigastric meal related burning pain, experiences sore belching, no biliary, no acute surgical abdominal signs, and suspected triggers were NSAID is used, stress, irregular meals, or potassium infection. So it was a very easy case of the peptic ulcer disease or gastritis. So clinical cues are epigastric burning pain, nausea and recurrent vomiting, sore belching, reduced appetite. Epigastric pain typically occurs 1 to 3 hours after meals or at the night. Common triggers are initial immortal physiological stress, irregular meal. Schedule H. pylori red flags where upper GI bleed, hematonesis or melena, or significant weight loss. If they are present, that can be red flag. So what are the key differential? Pancreatitis, in pancreatitis, there will be severe pain relating to big. In cholecystitis, there will be right upper quadrant pain. In GID, there will be right upper quadrant pain and persistent vomiting, causing dehydration, etc., and failure to thrive. So important investigation, clinical history checks, taking notes, take regular medication like NSAIDs, basic labs, to do. Then upper endoscopy is the gold standard. In mainly refractory symptoms, significant disease burden or alarm features are present. H. pylori workup not needed. Non-invasive test and treat must show endoscopy for functional pain. So histopathology, antimicrobial susceptibility. Generally they are not needed. Approach to treatment and updated guide: acid suppression, age-appropriate pharmacotherapy, stomach with mucosal line. You can say that can be healed by that acid suppression. Avoid the NSAID used. There will be structural meal times and stress management to be done. And targeted H. pylori eradication by the triple therapy, bacteria being targeted, tailored to susceptibility profile, strict 14-day duration. So guideline update: if susceptibility testing is unavailable, avoid clarithromycin-based regimen due to rising global resistance in the medicine. Favor high dose amoxicillin plus metronidazole, or utilize bismuth-based quadruple therapy, and complication to stabilize hemodynamically, and endoscopic hemostasis also can be done. So the classical clue was epigastric burning, mean relationship, nausea, vomiting, possible GI treatment if severe. So why does this happen? High acid, weak mucosal defense, lead to gastric irritation, ulceration, resulting in pain, nausea, vomiting. So we already discussed. So history, CBC, stool local blood, endoscopy, H. pylori workup. Now next case, B100, the 7 years old male had a mild cold last week, purple rash over legs since 2 days, joint pain refusal to work since 2 days, severe abdominal pain since 1 day, and vomiting since 1 day. So purple rash, joint pain, severe abdominal pain, and vomiting. So child curls up in pain, no diarrhea initially, critical physical finding, rash is palpable, very important. So palpable purpura, abdominal pain, vomiting, edema present, arthralgia swelling is present, and kidney hematuria patella present. So why does this happen? Inflamed vessel, leak into specific body system, gut edema and bleeding are the specific driver for the severe abdominal pain and vomiting. So gut edema and bleeding, very important. So classical tube palpable purpura, abdominal pain, vomiting, arthralgia is dysentery infection. So differential diagnosis appendicitis in localized pain again, no purpura needed. Interstitial there will be episodic screaming, obstruction sign very present. In meningococcal there will be toxic sepsis contact, rash will be present, or endemic outbreak can be present. So hematoschwalling purpura, this is the IgE vasculitis. So there is a post-viral history symptom of a for the viral illness, skin, you can see palpable purpura mainly over the lower extremity, arthralgia swelling, that refusal to walk, GIT, severe abdominal pain, vomiting, edema with inflamed vessels, causing that abdominal pain, hematuria and kidney. So red flag, severe GIT bleeding in the form of melena, hematopoiesis, or severe renal involvement can be the red flags. So important investigation, urinalysis that is critical. Most essential immediate test to assess for the silent renal involvement. CBC, it rules out thrombocytopenia. So this was a non-thrombocytopenic crash. Renal function test, visit kidney, do the kidney test. Then abdominal ultrasound that's strongly indicated for severe GIT symptom. Look for complications like interception. So these are the differentials. And you can see state-wise management track, supportive care, monitor renal status, skeletal management, and reserve this skeletal management is mainly for the severe disease involving severe GI or renal disease. Systemic corticosteroids can be used like a prednisolone. And the complication management, surgical or radiological intervention, SOS, if intersusception is identified. So, this was the diagnostic trap. So high yield based on rash and pain, clinical recognition, urinalysis for renal involvement, CBC assess bleeding or inflammation, renal function vital, systemic chills. So this is very important. Now next is this Mishka Sharma, 12 years old female, recurrent vomiting since 3 weeks, early satiety since 2 weeks, upper abdominal fullness since 2 weeks, weight loss since 1 month, omits food after meal, feel full extremely quickly, no diarrhea. Patient reports history of hair pulling and hair chewing behavior. So what are the classical clues? Early satiety, post-meal moving, episodic fullness, palpable mass, behavioral clues like that is trichotillomania or trypophagia. And so why does this happen? Indigestible material like a hair fiber accumulates to form a massive gastric plug. Stomach physically cannot empty. So leading to backup, that is vomiting, and lack of space, that is the early satiety. So what are the differential gastroparesis? Gastroparesis may motility issue hoga, there will be no physical blockage, gastric outlet obstruction may be due to other structural causes, eating disorders, different psychological and symptomatic patterns. So this is the gastric based on what we will see. So this was the case, and the red flags was persistent vomiting, severe weight loss, obstruction, and the perforation. So what was the pathophysiology? The clogged drain mechanism. This clogged drain mechanism, that dense solid mass, mixed mass that decay the food, and the this Raffens's syndrome, the large gastric tract obesor with large long hair tail through a very long extension that to gastric tract obesor through the pylorus, and that can go into small intestine or jejunum ileum, and be halting the false diagnostic loop, and generosa gastroparesis cyclic vomiting that has to rule out. So investigation of choice is the upper GIT endoscopy, that is the definitive. उसमें compacted air वगैरह मिलेगा, या there will be ulcers, or abdominal CT with oral contrast that can be non-invasive vein, circumference intraluminal gastric mass, sponge-like gas pattern will be Good. So what are the four-step treatment action plans? Stabilize with the acute hydration support, then diagnostic and therapeutic endoscopy, then surgical intervention, that is gastrostomy, open or laparoscopic gastrostomy, to extract the entire air mass, so there will be no distal fragment remain, and comprehensive psychological assessment, mental health, and this prevent recurrence for underlying these impulse control issues. So post-meal vomiting plus early satiety plus hair chewing history, that thing gastric resolve. So this is very important. Uh, so we are seeing these three cases: gastritis, IG vasculitis, gastric ulcer. In gastritis or peptic ulcer, there will be epigastric burning. In IG vasculitis, severe diffuse abdominal pain. In gastric ulcer, fullness or only satiety is present. What is the classical clue for peptic ulcer? Male relationship or sore belching. In solid purpur, there will be palpable purpur or arthalgia. In gastric ulcer, there will be behavioral history, positive hair chewing history will be present. Peptic ulcer, there will be endoscopy and acid depression, acid suppression. In HSP, we have to do urinalysis and renal mapping we have to do, and gastric ulcer, endoscopy or surgical one is required. Okay, so red carpets are the blood clots are the metamesis or malina that can happen in purine gastritis. Pancreatic bleeding can occur in peptic ulcer or HSP. Anemia can occur. The pain and system threats, even persistent unyielding pain, in all these three conditions can occur. Interception can occur in HSP. Renal involvement and hypertension can occur in HSP. So the obstruction rate, severe weight loss, that can be due to Bezor or peptic ulcer. Complete obstruction or persistent vomiting can due to Bezor, and gastric perforation, that is rare, but that it can be due to severe Bezor complications. We have already discussed these cases. So we will move now. It's a whole star, old star creates a new trophic disaster. The ghost of the past returns to disrupt the present. So the Bhoot Bangla movie. There's many movies in Bhoot Bangla, then Bhoot Bhalaiya, most. So, 11 years old with chief complaints with crampy abdominal pain, repeated vomiting, progressive bloating, no stool passage or no platters. History of present illness. 1 year ago, there was abdominal history. This was a major clue. And we can see that in zone 1, proximal bowel dilated, backup up leading to repeated vomiting. Now, zone 2, that is the structural key. That is mainly due to post-operative adhesion physically blocking the passage. And on distal bowel, there is collapse, empty, resulting in no stool and no flatter. So this was a very nice slide about this structural key of the bowel in between structure king and distal bowel. So this was a mechanical small bowel obstructions. You can see classical tetrad is crampy abdominal pain, recurrent vomiting, progressive abdominal distension, and absolute observation. Historic clue was a surgical scar, and the physical examination was a tachycardia with a monitor, visible distinct bowel which were present. On auscultation, there was a hyperactive high pitch thinking bowel sounds, and then bowel fatigue, and then impending issue that lead to silent abdomen on the auscultation. So very important. This mainly highly suspected to be secondary to post-operative adhesion given cervical history. Important history, basic lab to hydration status, metabolic panel to see the correct hypokalemia and alkalosis or acidosis, serum lactate and critical marker. So abdominal radiograph initial screen in supine that can show dilated small bowel groups. In erect, there can be lack of gas in distal column. CT abdomen with IV contrast is the gold standard. So this is the precise transition dose. Etiology adhesion. Evaluate complications like a bowel wall thickening and the pneumatocyst intestinal ease. So approach to the treatment and updated guide: initial resuscitation and decompression, drip and suck, decompression, hall vomiting, the non-operative management. In absence of peritoneal ischemia and adhesion, that can be managed by the conservatively for 48 to 72 hours. Now, updated guides: water soluble contrast challenge, gastrobriefing can be added. You can do serial X-rays after 6 hours, 12 hours, 24 hours. That can therapeutic drawing the fluid, and that reduce the bowel wall edema. Now, surgical intervention: invasive surgery when it is required, ischemia, strangulation, perforation, and presentation, and delayed surgery there is when is it fails, nothing or the conservative after 72 hours or fails gastrographic challenge, we can use this surgery. So you can say ki so distended and abdominal assessment, distended and tender visible volume. So it's possible. And general elbow, each child dehydrated tachycardia, early phase high pitch sounds I already discussed, and late phase was a silent sound due to bowel fatigue and ischemia. So now differentiating. Adult obstruction mainly there will be positive surgery history. In constipation, there will be chronic long-term pattern. In volvulus, it often more acute and catastrophic onset. And the gastroenteritis, there will be presence of diarrhea. So this was a stepwise investigation staircase we already discussed. Red flag, delays omitting peritonitis, shock, ischemic concern, and persistent severe pain. So we have already discussed nothing, no oral intake, IV fluid, and NG discompression, surgical treatment, and operating management. So, so omitting plus distinction plus prior surgery plus no plaques, obstruction and be excluded. So now next case we will see the we already discussed this case, the hair pulling and hair chaining behavior. We can see this diagram. Gastric basal we already discussed. Clogged drain system, or we can say. And okay, so we move to the another case that is very interesting case. Ritvik Malhotra, 16-year-old male, 4 months of severe recurrent vomiting, severe nausea, abdominal discomfort, and repeated emergency visit, severe dehydration. Multiple medical evaluation have returned completely normal result. And what is the hidden trait? Repeat regular heavy cannabis exposure discovered during confidential adolescent history, and spends exceptionally long periods taking very hot showers for symptom release. Very important. So cannabis history and very hot showers he was taking. And this was the adolescent, 16-year-old. So the Bazigar, his friend turns enemy. So you can see the hot shower, how this happened. Then it can use as an anti-emetic. But later on, this there is paradoxical hyperemesis due to massive chronic receptor overload. So the mechanism is cannabinoid hyperemesis syndrome. Chronic cannabinoid exposure paradoxically dysregulates central emitting pathways. So friend that turns against you mechanism. So we already discussed this Bazigar what look like a trusted friend, anti-emetic becomes a villain, that is hyperemetic attacker. Okay. So acute hydration, symptom control, cannabis cessation, and counseling is required. And so pathognomic clue was the hot shower relief and definitely stop cannabis. Severe dehydration, electrolyte dearrangement, diagnostic uncertainty are the red flags. So it's very important. And so this was a one slide we can say. So very important. The key there is a this what critical diagnostic signs for pathognomic hot shower relief, chronic high frequency cannabis exposure, intense cyclic hyperemesis, and the clean state diagnostic frustration. And in this investigation choice was Rome for framework, clinical diagnosis, urine toxicology screen, and targeted basic labs that will also organic use. The basic labs are electrolytes, renal function test, lipid test, and so the particular paragraph friend turns enemy. So in low dose physiological, normal receptor act as anti-emetic, but in chronic high dose, down-regulated receptor and that pro-emetic intense vomiting occurs. So splanchnic steel phenomena occurs. Now the hot water divert the flow and hypercongested splanchnic vasculature, you can say, and this hot water that cause steel that reset enteric nervous system. So splanchnic steel phenomenon is very important. So what is the standard treatment protocol? Step one is the aggressive acute hydration, balance isotonic crystalloids like a ringer lactate, kidney function we have to monitor, metabolic alkalosis we have to correct. Then there is a ineffective standard antiemetics like ondansetron, and then topical capsicum cream we can use to apply the abdomen or thorax. Mechanism is the this TRP1 stimulation and the substance P depletion mimicking the hot shower. And IV haloperidol or olanzapine low dose dopamine antagonists can be used as a central abortive agent. Olanzapine is preferred, that is lower EPS and excellent relief. It is a D2 antagonist. And cannabis cessation is a definitive cornerstone that's universally successful and total and complete cessation. And comprehensive care, counseling the family, counseling the patient, that is cognitive behavioral therapy. So it is very important. So cyclic force meal emesis plus compulsive hot showers plus chronic cannabis exposure that diagnose is cannabis hyperemesis syndrome. Now, next case. Arthan Chitale, 9 years old, male, 4 months of progressive feeding difficulty with cheek complaints, chronic episodic vomiting, poor weight gain, food refusal, episodic abdominal discomfort. Patient eats very slowly, avoids certain textures, drink excessive water with food to force it down. No acute infection picture. The hidden trait was strong personal history of atopy, like eczema or allergic rhinitis or possible asthma. So atopy was present and difficulty in swallowing, progressive feeding difficulties. So you can see the mechanism. So diagnosis is a eosinophilic esophagitis. Allergic immunoinflammation triggers heavy eosinophilic infiltration. This causes severe esophageal dysfunction, making normal food transit mechanically and functionally difficult. So the allergic, you can see the border allergic checkposts. Uh, so dietary strategy, evidence-based elimination diets, then condition-specific management, where to do GI follow long-term tracking and nutrition support if growth is affected. So definitely diagnosis is a biopsy. Endoscopy is very critical. Major association is atopy, red flags, food impactation, progressive dysphagia, poor growth, severe feeding refusal. So we already discussed this case. Okay, so definitely esophageal biopsy showing heavy eosinophil counts. So sorry, so this was the summary of the eosinophilic esophagitis. So generally age-dependent presentation, then compensatory feeding behaviors like a slow eating, cutting food, texture avoidance, and drinking excess water. And atopic triad-linked eczema, asthma, allergic rhinitis can be present. And critical red flags, food impactation, problem, dysphagia, core that I already discussed. So what are the clinical pulse? It's allergic traffic checkpoint. So Th2 response, and that causes eosinophil infiltrate the esophagus, and that causes tissue remodeling, and that causes esophageal vulnerability, that causes failing type of esophagus. Rings or furrow on endoscopy can be seen, that crepe paper esophagus and occur. And investigation of choice is upper gastrointestinal endoscopy with multiple mucosal biopsy. So peak eosinophil count more than 15 eosinophils for a high power is the diagnostic. So multiple biopsies is important. So dietary elimination, like milk, soya, wheat, eggs, nuts, and fish and bread. So you have to see the insulin allergy you can eliminate. Then first line medical therapy is a protein pump inhibitor, weight based, BID dose, 8 weeks you can give. Topical corticosteroids like a puff, fluticasone or budesonide can be used. Avoid eating or drinking for 30 minutes after that use of the topical corticosteroid. And long-term GIT follow-up and response is very important. Repeat endoscopy biopsy after 8 to 12 weeks is required. Individual food reintroduction is required. Step 4, advanced mechanical mitigation, esophageal balloon dilation for fixed stricture. So clinical parameters, so we already discussed this. So now we can see the two cases are compared: eosinophilic esophagitis and the this cannabis hyperemesis syndrome. So we already actually have discussed these cases, so I will not go in again detail. So this was the summary the case. So now next case we will go. The mechanical backlog, that is 12-year-old male, omitting consists of undigested food, not through acidic emesis since 6 months, dysphagia since 5 months, weight loss since 3 months, night cup since 1 month. The vital clue was omit consists of undigested food and not through acidic emesis. So aspiration indicators night coughing and choking, and compensatory action was to drink water to force food down. So in this patient, there was a vomiting, but undigested food. And how much the age? 12 years old male. There was a dysphagia, weight loss, and the night cough. So this was the aspiration indicator also. And patient was drinking water to force the food down. So the locked restaurant door. So lower esophageal sphincter fails to relax, impair esophageal motility, food piles up at the entrance, and you can see this classical birth peak appearance was the diagnostic feature. So hydration, nutrition support, definitive procedural therapy required, aspiration prevention is critical priority, monitoring, definitive test was the manometry. So classical imaging showing one big sign and definitive visual or manometry. So red flags in this aspiration, severe weight loss, and inability to swallow liquid. So we can compare this case, this what in case eosinophilic and CHS calcia. So this was the culture. So do not miss red flags. In any presentation of chronic pediatric conditions, rule out these acute traits before beginning stepwise investigations. Metabolic alerts like severe dehydration, severe electrolyte derangement, then airway or mechanical alerts like aspiration, night choking, complete inability to swallow liquid, structural or growth alerts, food impactation of obesity, dysphagia or severe growth restriction. So linked to the eosinophilic esophagitis or acalcia, and aspiration night choking that links to acalcia. So we'll move to the next case. Okay, so 8 years old female, it is this Bollywood analog tunnel, an open passage that become dangerously impassable. So 3 months ago, patient had a proteoprotein vomiting, regurgitation begin, difficulty in swallowing solids and food sticking sensation since 2 months. Since 1 month, there is a weight loss and presently prolonged chewing and drinks excess water with meals, regurgitation shortly after eating, and no acute infection. So funnel of dysphagia, solid gram, liquid pass through, flows freely. So structural narrowing in the esophagus, food passes obstructed, and that causes regurgitation and vomiting. The golden clues, solid first and liquids later, etiology. So clues consider previous caustic ingestion, severe reflux injury, post-surgical complications, or congenital. So narrowing is present. Key differentiation, acalcia, motility problem, eosinophilic esophagitis allergic problem, and the GRD is the reflux problem. So history, the most critical tool for tracking progression, contrast swallow, visualize the anatomical narrowing, endoscopy, the best direct test critical for visualization, and biopsy for the selected case, point for etiology. So nutritional support, endoscopic dilation is the treatment, treat underlying case like a gastric GRD, then surgery for the complex case, and the red flags can be aspiration rates, complicated liquid swallow liquid, severe weight loss, contemporary history. So next case, 5 years old male, this presented 6 months ago with poor weight gain, that is growth faltering. 3 months ago, loose bulky false smelling faces, and 2 months ago, recurrent vomiting and severe irritability. And so, what is the molecular nose? So, there's the factory exists, but the workers are damaged and the output is ruined. Okay, so you can see, so this that Shah Rukh Khan, after returning from the foreign, there was no picture के आता है गांव में actually बिजली नहीं रहते, so how he use his brain and technology and start electricity in his village. So healthy villia, you can say there is efficient absorption, but in damaged villia there will be bulky faces and nutrient loss. So pathophysiology is immunomediated gluten triggered like rye, oats, gluten diet. Small bowel bilious injury occur that causes severe malabsorption, and the severe malabsorption and that the systemic GIT symptom will generally present with the diarrhea, but there will be a greasy, oily, bulky stool with very foul smelling stool. And so classical clues are chronic poor growth and distension and malabsorption stool pattern plus anemia. So select में malabsorption pattern रहेगा, CMP में younger infant में होता है, and IBD में inflammatory features रहेंगे like bloody stool or abdominal pain. So select disease, damage absorption factory. Okay, so you can see this tall finger like villia, this maximum nutrient absorption normally, but in select disease there will be villous atrophy, flattening that reduces absorption. The factory is damaged. So what is the initial high yield screening? Serum IgA, anti-tissue transglutaminase, that is the primary test, more than 90% sensitivity and specificity, and total serum IgA must be measured concurrently. So ये Shankar और Nandi की जोड़ी है. So we have to do the serum IgA, anti-tissue TTG plus total serum IgA simultaneously. If Ig is deficient, then use IgG based test like a DGP IgG or TTG IgG. So no biopsy pathway, that is gone guidelines. Biopsy can be avoided if this TTG IgA titer is more than 10 times the upper limit of normal, or EMA IgA, that is anti-endomycin antibody positive on a separate blood test. So upper GI endoscopy and duodenal biopsy use if no biopsy criteria not met, at least 4 to 6 biopsy from bulk and distal duodenal. Mass classification is like intraepithelial, lymphocytosis, crypt hyperplasia, villus atrophy, partial or total. So that onset timeline symptom emerges weeks to months after introduction of gluten. Gluten means that wheat, barley, and rye. So usually between 6 months and 2 years of the age group generally, right? So what is the treatment? Lifelong gluten-free diet, strict lifelong elimination of wheat, rye, barley, even microscopic cross-contamination sustain the inflammation. So poor oats allowed only if they're certified gluten-free. Nutrition correction, you can see iron, folic acid, fat soluble proteins like ADK and zinc. Then lactose restriction, because restrict dairy lactose for the first few weeks to reduce bloating, gas, and loose stools, while will regenerate lactase at the we like tips. And growth monitoring, track height, weight, and BMI on growth charts, monitor TTG IgA at 6 and 12 months, then annually to ensure diet adherence and mucosal healing. So very important. So malabsorption triad is chronic diarrhea, pale, bulky, greasy stool due to steatorrhea, abdominal distension, and growth faltering or wasting. And that onset timeline, you can see age group 6 months to 2 years. And generally, we try extra intestinal symptoms like short stature, delayed puberty, recurrent mouth ulcers, increased transaminase, distal enamel defects, or iron deficiency anemia can be present. And irritability parameter, mark irritability, lethargy, anorexia, that may be early sign of nutrient depletion and intestinal discomfort. So what is that broken conveyor belt? Immunological destruction. Gluten is modified by TTG in the lamina propria, triggering a T cell mediated autoimmune attack that destroy villi and impair absorption. The silent celiac iceberg. Many cases are silent. Screen high risk children, mainly like diabetes, insulin dependent diabetes, with Hashimoto's thyroidosis, Down syndrome, Turner syndrome, Williams syndrome, first degree relatives also we can see. And danger of early diets: do not start a gluten free diet before testing. It lowers antibodies and heals the mucosa, so invalidating serology and biopsy results. So goal is heal intestine, restore nutrition, normal growth, better quality of life, and treat the cause and not just the symptoms. So we already discussed this. Um, okay, okay, so this, I think, organic acidemic is I have discussed already. So we'll go to the next case. Okay. So the salt battery cooler, the robot, Rajnikant and Rakshita movie, the Ashura, the machine looks normal at first, then suddenly it's electrolyte battery dies. So the case, Advika Kulsrishta, 14 days old female, presented with the recurrent vomiting since 2 days, poor feeding and weight loss and rapid onset lethargy, and hidden flu was the ambiguous genital notice at the birth. So the diagnostic rivalry is sepsis, infection pattern, pyloric stenosis, later onset metabolic hypertension, and this Advika is having congenital adrenal hyperplasia. So it was a neonatal onset, patient present with neonatal severe shock and ambiguous genital. So neonatal vomiting plus shock plus hyponatremia plus hyperkalemia gives a 21 hydroxylase deficiency. What happens in 21 hydroxylase deficiency? There is decreased cortisol, decreased aldosterone, that will cause massive salt loss and dehydration. So this is the slide I have made specifically. So over 90% of CH cases are caused by congenital mutation in CYP21A2 gene, leading to 21 hydroxylase deficiency. This enzymatic block halts the synthesis of both cortisol, leading to hypoglycemia and interferring shock, and aldosterone, leading to massive renal sodium wasting, profound volume depletion, and potassium retention. So what are the critical exam signs? Shock paradox. profound, unremitting hypertension and circulatory shock, entirely refractory to standard vasopressin and fluid boluses, unless exogenous glucocorticoids are administered. Salt wasting timeline. Classical salt wasting C is typically present between 1 to 3 weeks of life as a neonatal aldosterone reserve depletes. Affected infants exhibit poor feeding, progressive weight loss, unremitting vomiting that mimics simple GIT illness before rapidly sliding into the cardiovascular collapse that is no shock. And Ambridge's genitella, the genetically female 40XX unit, virilization, clycromegaly, partial labioscrotal fusion, urogenital sinus can occur. Affected male 40XY have a normal male genitella or subtle hyperpigmentation, harder to detect clinically before presenting in acute shock. And hyperpigmentation, elevated ACTH level cross-reacts with the melanocortin 1 receptor, causing noticeable skin hyperpigmentation and most prominently on scrotum, labia, nipples, and palmar creases. So diagnostic rivalry we already discussed. So investigation of choices: serum 17 hydroxyprogesterone, 17 DHP, that diagnostic massive backup in serum 17 OHP, massive backup in this all this. So the classical electrolytes are hyponatremia, sodium less than 130, hyperkalemia, more potassium more than 6.5, low chloride and metabolic acidosis, secondary confirmation, karyotype and ultrasound showing this all this. And so what is the emergency protocol for the treatment of congenital adrenal hyperplasia? Emergency ABCs and aggressive fluid resuscitation, establish IV or intraosseous immediately give normal saline at 20 ml per kg or 10 to 20 minutes. Never use potassium containing fluids like a ringer lactate during initial resuscitation. Very important. Normal saline we use करना है. Ringer lactate नहीं. Immediate glucose correction. Check bedside glucose. Correct immediately with IV bolus of 10% dextrose, 2 to 4 ml per kg followed by continuous dextrose infusion. And hydrocortisone administration, that is the ultimate lifesaver. Administer immediately high dose IV stress dose bolus hydrocort 50 to 100 mg per meter, follow with maintenance 100 mg per meter divided every 6 hours. Avoid dexamethasone if possible, as it completely suppresses the adrenal axis and invalidates diagnostic testing if 70 OHP draws have not been completed. And strict hyperkalemia monitoring and electrolyte management is important. ECG करना है, ECG में होगा तो calcium gluconate देना है 10%, then followed by insulin dextrose shift and then nebulized albuterol salbutamol we can do. And one stable patient oral fluid cortisone or sodium chloride can be added. So non-neonatal vomiting plus shock plus low sodium plus high potassium presumed congenital adrenal hyperplasia. Begin stress dose hydropods. So the pressure, now the next case, the Singham, pressure rises until the whole system is about to explode. Aptamaji Satekli by Rajirao Sangham, Ajay Devgan. So Naveed Chowdhury, 13 years old female, presently with severe headache, vomiting since 1 day, blood vision, irritability, and escalating to the encephalopathy. The climax is one seizure an hour ago. So what is the mechanism? Severe blood pressure elevation that cause end organ injury, that cause cerebral edema and encephalopathy, and that leads to vomiting and seizure. So measure BP correctly with proper cup size. It is a defining clue. The illusion was migraine, headache, vomiting, but normal blood. So migraine में BP normal रहता है. Meningitis में there will be fever and all these Brunzinski and these signs will be present. Okay, so but this is the case of the hypertension. Okay, so markedly high BP, driving, visual loss, and end organ clues. Okay, so measure BP correctly. So this was the case. You have to just see proper cup size imperative, very important, weight more than 40% of arm circumference, and length should be 80 to 100 arm circumference. And the warning, autoregulation shift, abrupt BP drop triggers cerebral ischemia or watershed infarct. So that is very important. The अचानक बीपी एकदम बीपी फास्ट रिपेयर ये नहीं करना है. And hypertensive encephalopathy, rapidly rising pressure overcomes the cerebral autoregulation and capillary leak and blood-brain barrier breakdown, and that was localized cerebral edema. So continuous intraarterial BP is the monitoring, is the investigation of choice for the tracking And the rapid target organ lab bundle can be urinalysis and renal panels to see immature protein elevated creatinine, fundoscopy for the fresh retinal hemorrhage, soft exudate papilledema, neuroimaging brain MRI or CT scan that differentiates cerebral edema from the intracanal hemorrhage. So very important. So the what is the protocol? So immediate control protocol is the set wire that is admit instantly to ICU. Then control gradual BP reduction is the golden rule. Reduce BP by the maximum 25% of total planned reduction in first 4 to 6 hours. Slowly taper remaining inhibition over 20 to 48 hours until age height appropriate percentile is achieved. The first line is IV pharmacotherapy, continuous titrable infusion required. Labetalol is alpha or beta agonist. Antagonists avoid in asthma or heart failure. Nicardipine, calcium channel blocker, that is predictable cerebral vasoprotection. And sodium nitroprusside, refractory cases require strict monitoring for the thiocyanate toxicity. So manage seizure immediately. IV benzotiazone, lorazepam, or levocetran can be given. Don't. So what are the don't lethal pitfalls? Danger wire. Dropping BP too fast causes catastrophic reduction in cerebral perfusion pressure that can cause massive irreversible ischemic damage. Utilizing sublingual nifedipine, that obsolete and dangerous. Unpredictable precipitous drop, and that can cause reflex tachycardia and the stroke and the myocardial ischemia. Okay, so what specific? These all severe headache, vomiting, visual loss, and seizure, and that lead to encephalopathy. So intervene immediately in such a cases. Okay. So now, we already discussed this case. Now the next case, the Ira Mukherjee, 16-year-old female, presented with the severe abdominal pain, vomiting since 2 days, constipation, anxiety, restlessness, and agitation, and new development was emerging limb weakness. So Bulbulaya, we have seen the movie featuring the Akshay Kumar and Vidya Balan. The first part I am talking. Third part was also spread. A mysterious hidden process creates bizarre symptoms. Nobody initially understand. Okay, so the heme pathway is enzyme is there is a defect. Toxic precursors accumulate, and that causes neurovisceral crisis. The clue was pain. Pain was grossly disproportionate to the benign abdominal exam. Tachycardia, hypertension, and autonomic instability was present, precipitated by a trigger like a fasting specific drugs or hormonal shifts. And what is the diagnostic value or DDs? In appendicitis, there will be localized finding and clear the right like for some pain and clear GI. But in acute for this era child, severe pain, constipation or vomiting, plus neuropsychiatric clues that are zero local physical findings present. So this is the acute AIP slide I have made. Neurovascular, this was a classical clinical trial, neurovisceral abdominal pain, ascending motor neuropathy, and neuropsychiatric alteration. So severe unexplained colicky soft abdomen on examination, no peritoneal signs or guarding, nausea, vomiting, profound constipation. This is the first. Second, ascending motor neuropathy, frequently miming Guillain-Barré syndrome, weakness beginning legs, ascent proximally, progress to respiratory paralysis or quadriplegia, and neuropsychiatric alteration, toxic metabolic blood-brain barrier that causes anxiety, agitation, insomnia, and depression, and hallucination and psychosis. So the investigation, first line investigation, spot urine sample measuring this porphyrin levels, then ALA levels, then active crisis, this urinary PBG typically more than 10 times upper normal. Then immediate resistant strategies, discontinue potential offending medication, administer IV or oral dextrose, and there's carbohydrate loading. Then the aggressive daily intravenous hemine, we can consider novel prophylactic treatments like Geosiran or prevent attacks. So what are the high clinical pearls? port wine urine glue, darkness on exposure to air or light, that PBG polymerize, complete absence of skin findings. No cutaneous manifestation of photosensitivity or blistering rashes. Autonomic instability like a tachycardia, level hypertension, excessive sweating, urinary retention, and electrolyte derangement like a hyponatremia, hypomagnesia present, and trigger deficiency symptom latent until provoked by the specific environment and physiological triggers. So what is the treatment? IV fluid and carbohydrate resuscitation. Objective is to suppress hepatic ALS1 transcription. So we have to deliver 300 to 400 glucose per 24 hours. So electrolyte correction critical to avoid hyponatremia risk. Infuse carbohydrate in isotonic saline. Then the never use P450 inducers that cause fatal respiratory paralysis risk. So verify any new medication against the dedicated international porphyria database, European Porphyria Network or NAPOS we can use before administrations. These are the drugs which can cause porphyria, ketorolac, certain combination NSAIDs, vitacloramide, calcium channel blocker, phenytoin, phenobop, carbazepine, valproate, barbiturate-based sedatives, they can precipitate porphyria. So execution of the emergency protocol, half fasting days, immediate cessation of caloric restriction, rely on heat and water if oral intake is impossible, and admit to the PIC, continue pulse oximetry and spirometry to track forceful vital capacity every 2 to 4 hours, dropping FUPC that can impede diaphragmatic paralysis and then intubation before crash, and transition to heme. Carbohydrate loading is a breach and not a cure. If severe symptoms, neuropathy, hyponatremia, uncontrollable pain persist beyond 24 hours of glucose therapy, immediate transition to IV hematine arginate at 3 to 4 mg per kg per day to shut down the toxic loop. So weakness progression, ascending motor neuropathy can lead to fatal respiratory involvement and severe autonomic instability. So this is very important. These were the 3 cases we have discussed. So vomiting plus ambiguous genital plus shock, you think adrenal crisis, and vomiting plus vision changes plus seizure, brain under pressure, vomiting plus constipation plus crazy pain plus normal exam, you think of metabolic plus. So what is the classical neonatal electrolyte pattern? Low sodium hypertension, 21 hydrogen defect. What is the most dangerous mistake in hypertensive emergency? Dropping the blood pressure too fast. And what is the definitive mismatch in acute intermittent porphyria? Severe agonizing pain coupled with minimal physical abnormal findings. So master the clue, save the patient. Vomiting is the opening sequence. You now have the script to uncover the true log. So now next case, last 3 cases are remaining. So we'll discuss fast part. Party 10 years old male with recurrent abdominal pain, episodic vomiting since 4 months, brief ultra-avenous episodes since 2 months. Very important. Brief ultra-avenous episode. And post episodes, there was a sleepiness since 2 months. General examination is normal between attacks, rare but very important. So electric short circuit in the gut. So robot again a hidden electric glitch causes bizarre intermittent system. So gut short circuit. The glitch, sudden abdominal discomfort, nausea vomiting phase 1. In phase 2, there is a crash, tearing pain, release responsiveness, unusual behavior. In phase 3, there is a reset, normal between attacks, and the draining pattern, pathophysiology, the neurological exhaustion, epileptic electric discharges involve autonomic temporal networks. The gut symptom dominate, but the neurological exhaustion remains. So what is the classical cue? Episodic abdominal symptom, alter awareness, stereotype episodes, post-event sleepiness, normal between episodes. So red flags, prolonged alter consciousness, generalized seizure, focal deficits. Okay, so this was the case. So just you can see, remember. So I will not discuss due to time problem, but we can say essential diagnosis sign, abdominal pain, then associated GIT, autonomic symptoms, alter consciousness, post-ictal phenomenon, and diagnostic sign objectively EEG. Abnormal EEG requires spike, sharp waves, temporal or frontal, interrectal or rectal. Normal does not exclude abdominal epilepsy. Prolonged or video EEG is needed. Neuroimaging is mandatory to rule out structural causes like a mesial temporal sclerosis or cortical dysplasia or low-grade tumors, and complete GIT workup, document normal upper GI endoscopy, colonoscopy, ultrasound CT for appropriate to rule out organic GIT disorders. So management will diagnostic therapeutic trial, definitely diagnosis by response to anti-seizure medications. Then first line anti-seizure medication is oxcarbazepine or carbazepine instead of currently first line. Excellent for focal epilepsy. Levetiracetam prefer in pediatrics. Monotherapy, favorable side effect profile. There are less side effects, less sedation, no hepatic injection, and rapid action. Behavioral warning. But there is a behavioral warning mentioned in the Vera use. Sodium valproate effective caution in young children that can cause hepatotoxicity, avoid in females, especially in childbearing potential. Good if generalized component. So long-term follow-up and prognosis. Prognosis is favorable. Most active revisions with monotherapy, monitoring neurologist follow-up, monitoring levels, side effects with rehabilitate medication need, and many are being after year seizure free. So this was the EEG screening protocol. Routine awake sleep EEG we can do. Then prioritize sleep deprivation to unmarked SID. Provocation techniques like hyperventilation for 3 minutes or strobe lighting or photic stimulation can do done. That can provoke subclinical electric abnormalities or sometimes prolonged video EEG monitorings for 24 to 72 hours. That is a golden standard diagnostic is important. The objective is link abdominal symptom to abnormal cortical firing. So the AD titration schedule I am not going to discuss. Initiation, titration, week 1, week 2, 3, maintenance phase, and surveillance. So first we start with 8 to 10 mg per kg in week 1, then in 2 to 3 increase by 5 mg per kg every 7 days, and maintenance we to use 20 to 30 mg per kg per day, and surveillance routine follow up at 1, 2, 3, 6 months. So dramatic and complete cessation of paroxysmal abdominal pain, vomiting, staring spells once cerebric threshold is reached. Okay. And the this monitors serum sodium levels. There is hyponatremia swelling, and annual follow-up EEG is required. So, and confirm the complete cessation of GIT and neurological symptoms. So we already discussed this. So now next case, the last two cases, uh, uh, Ms. Maisha Khare, 7 months female, repetitive vomiting since 3 hours, lethargy since 2 hours, pallor since 2 hours, poor response since 1 hour, introduced to new complementary food earlier that day. Very important history. So delayed allergic ambush, baby movie, they call Akshay Kumar, patriotic movie, Anupam Kher was also there. The attack doesn't happen immediately. The ambush comes later, delayed ambush. So there was a food history and then vomiting, lethargy, pallor, and poor responsiveness occurred. So this is a generally this is in classical IG allergies, their immediate reaction after 0 to 15 minutes. How this IG mediated hives, wheeze, or immediate anaphylaxis can occur. But this is a food protein induced enterocolitis syndrome. This is a non-IG mediated. This is delayed ambush, non-IG food reaction that causes intestinal inflammation that present in 2 to 4 hours. Symptoms are suddenly ill, repetitive forcible vomiting, extreme pallor, lethargy, progress to diarrhea and shock. And diagnostic differentiation versus sepsis is FEI lacks the progressive infection context, and gastroenteritis contagious GIT pattern is present. So this was the pathophysiology. You can see full protein ingestion. There is a localized T cell activation that causes the release of pro-inflammatory cytokines, and that can cause enterocolitis, and that increases intestinal permeability. So routine allergy testing is typically negative, skin prick or serum IG. Supportive lab is neutrophilia, sometimes after 6 hours can occur, metabolic acidosis. But what is the definitive confirmatory test in this food protein induced enterocolitis syndrome is a supervised oral food challenge only after stabilization. So stabilize the airway, breathing, and circulation. Identify red flags like a shock and severe dehydration. Aggressive IV fluid treatment is required, like a normal saline bolus, 20 ml per kg over 10 to 20 minutes. IV methylprednisolone we have to give, and epinephrine is not indicated. Remove trigger and long-term dietary planning. Strict avoidance of culprit protein and allergy follow-up for dietary roadmap. So complementary food introduction plus repetitive misses at 2 to 4 hours plus shock or pallor or helps that diagnose food-induced food and protein-induced enterocolitis syndrome. So stabilize we already discussed. So the last case is the Harshvardhan Jain, 9 years old male, presented with recurrent vomiting, nausea, poor appetite, and abdominal discomfort. Clinical contest recently started new medication, no clear infection progression. The trope is the treatment that backfired Bollywood analogy, Bazigar, using Shah Rukh Khan, Shilpa Shetty, and Kajol. The trusted helper unexpectedly becomes a problem. Okay, and so backfire treatment. So the pathway one is direct gastric irritation. Pathway two is a CNS emetic trigger stimulation. Pathway three is a metabolic side effect. Pathway four is system toxicity. So usual suspects are antibiotic, iron supplementation, anticonvulsant, chemotherapy agent, NSAIDs, and OTC drugs or counter drugs used and herbal drugs. So temporal relationship to medicine is very important. Onset begins after starting the drug, improves when culprit is addressed. सो मेडिकेशन हिस्ट्री लेना चाहिए, टॉक्सिसिटी असेस करना है, डोज लेवल देखना है, ड्रग इंटरेक्शन देखना है, टारगेटेड लैब टॉक्सिसिटी प्रोफाइल लेवल्स देखना है, is very important. And so what are the red flags? If there are overdose suspicions there, or ultrasensorium is there, severe dehydration is there, arrhythmia is there, severe toxicity signs are there, just that. So most important diagnostic clue is temporal relationship, common mistake, missing OTC and herbal history. So this is the case of the medication in this vomiting. You can say all these pathways, direct gastric, it causes localized inflammation, mucus slumping, CNS, that dopamine receptor or PI3 or NK receptor, and the chemoreceptor trigger zone is lying in medulla. Then the pathway 3, metabolic systemic toxicity, acid-base imbalance that can cause. And the diagnostic clue, you can say, the key diagnostic medication start 1 to 3 days into onset होता है, तो retrospectively also we can do. Persistent nausea, anorexia characteristic listed. MSS, usual suspect we already discussed. Then the investigation we already discussed. Serum drug levels like acetaminophen, salicylate, anticonvulsant. ECG, monitored conduction delays or arrhythmia. Metabolic renal findings like electrolyte blood gas. So toxicity red flags, overdose suspensions, ultrasensorium, arrhythmia, severe dehydration, and toxicity. So identify and isolate, cultivate, modify therapy, safely, aggressive supportive care, imaging toxicity input. So this is very important. So stop or modify drug and think medication induced. So these were the three cases: abdominal epilepsy, FPIs, and medical induced. So so this is the way the all cases I have completed related with the mainly omitting. So now I think we can go for the question and answer sessions.
Yes, sir. Thank you so much, sir. Such a deep and practical session from your side on such an important topic. So can I go ahead? I already sent questions, sir. You can check it.
Yes. Yes.
So can I go ahead and can I read it out for you, sir?
Yes, 100%. First question.
So the first question is that how, as per your experience, sir, how would you evaluate the withholding behavior clinically, and what are what are its long term implications?
Yes. So withholding behavior, mainly it is related to the constipation. So
Yes.
stool withholding is most commonly associated with the functional constipation. Pain. So what is the case history? Painful defecation preceding the symptoms. Infrequent stools, less than 2 to 3 per week. Passage of large caliber stools and retentive posturing, standing stiffly, then crossing the legs, then hiding in the corner or tiptoeing, and fecal soiling, that is encoparesis can occur, and टॉयलेट को रिफ्यूज करने के लिए वो टॉयलेट रिफ्यूज करता है और टॉयलेट एंजाइटी होती है. So physical examination में abdominal fecal mass or we can get lump, then perianal fissures, rectal stool loading can be seen, and growth assessment we should do. There may be growth failure. Neurological examination of lower limbs and spines is very important. Sometimes there may be sacral defect, canal defect. There are top hairs on the lower part of the sacrum. Then what are the red flag suggesting the organic disease? So delayed meconium more than 48 hours. जैसे बच्चा जन्म हो गया तो उसके हिस्ट्री पूछना है कि 24 घंटे में उसने मेकोनियम पास करना चाहिए, लेकिन वो अगर 48 घंटे से ज्यादा के बाद मेकोनियम पास किया है तो दैट इज अ वेरी रेड फ्लैग. देन फेलियर टू थ्राइव, वजन और हाइट दोनों कम है. देन सिवियर एब्डोमिनल डिस्टेंशन, एब्डोमेन पूरा भरा हुआ है. Abnormal neurological findings, then sacral abnormalities that I have discussed, and blood in stool without the fissure. These are the red flag that is indicative of a organic disease. So long-term implication if untreated that can lead to chronic mega rectum, fecal impactation, overflow incontinence like encoparesis, recurrent abdominal pain, urinary tract infection, vesicoureteral reflux, psychosocial distress, and poor self-esteem. So clinical pearl is that longer withholding continues, the larger the rectum becomes, and weaker the urge to defecate becomes, and creating the vicious cycle. So this is about the answer about the first question, that is the stool withholding
Yes.
behavior.
Thank you, sir. And the next question is that how do you rule out cow's milk protein allergy when symptoms overlap?
Yeah, it is a very good question. Cow's protein allergy, generally it overlaps with the gastroesophageal reflux, then evening colic, functional constipation, infantile regurgitation. We already discussed the difference between regurgitation and vomiting, and eczema, that is atopic dermatitis. Now, what is the diagnostic approach? How to, what is the algorithm or protocol? So step one is the assess symptom pattern. So what are the features favoring this cow's milk protein allergy is the multiple organ involvement, eczema, blood or mucus in stool, chronic diarrhea, persistent vomiting, and family history of atopy in the form of atopic dermatitis, allergic rhinitis, or asthma or food allergy. Then second, elimination trial, extensively hydrolyzed formula or maternal dairy elimination in breastfeed infant, and usually for 2 to 4 weeks. वो करके देखना है दो से 4 हफ्ते के लिए. And then re-challenge. This is a very crucial step. That is the step 3. Symptom improve after elimination alone. Do not confirm CMPA. So diagnosis required, improvement during elimination, and recurrence after cow's milk reintroduction. यानी पहले स्टेप में क्या क्या किया अपन ने, विथहोल्ड किया, काउज मिल्क बदल दिया. सेकेंड में अपन ने एक्सटेंसिवली हाइड्रोलाइज फार्मूला यूज किया और मदर का मिल्क बंद कर दिया. और तीसरे स्टेप में, यानी ये तो दूसरा स्टेप जो होता है 2 से 4 हफ्ते के लिए, और तीसरे स्टेप में अपन ने फिर से काउज मिल्क इंट्रोड्यूस किया. सो फॉर डायग्नोसिस दिस 3 steps are very important. What argues against CMPA? CMPA कैसे नहीं है, कैसे अपन ये करेंगे? Just isolated uncomplicated regurgitation होगा, thriving infant है ना, there will be no failure to thrive, well-being baby वगैरह, no atopy, no gastrointestinal inflammation, no response to elimination. So clinical pearl is over diagnosis of cow's milk protein allergy is now more common than underdiagnosis in many pediatric settings. So this was the answer for the second question, that is about related with the cow's milk protein allergy. Third question.
Yes, sir. Thank you so much. And the third question is that, sir, is there any role for acid suppression therapy in purely physiologic cases?
We already discussed कि infant में तो PPI का रोल ही नहीं है antiproin. So answer is no. Physiological gastroesophageal reflux in thriving infant does not require protein pump inhibitors like this omeprazole, rabeprazole, lots of lansoprazole, or H2 blockers like ranitidine, famotidine, or any antacids. So most infant reflux results from the immature lower esophageal sphincter. We already discussed that case, or liquid diet and predominantly supine position. So this was tried, Trimurti, immature lower esophageal sphincter, liquid diet, mother का milk चालू रहता है और बच्चा supine position में सोता है. So it is not caused by excessive acid production. So when acid suppression may be considered, कब देना चाहिए ये protein pump inhibitor PPI तो when there is evidence of GRD, poor weight gain, bleeding refusal, hematemesis, endoscopically proven esophagitis, significant pain attributable to reflux. So risk अगर अपन ने यानी पेशेंट नॉर्मल है तो भी पीपीआई देगा तो क्या हो सकता है? So there is a increased respiratory infection, gastroenteritis, alter microbiome, and possibly increased allergy risk and nutrient malabsorption. So clinical pearl is happy spitter, जो अपन ने 26 नंबर का केस देखा था, happy spitter needs reassurance and not this omeprazole or protein pump PPI. So this is about the answer to third question.
And Doctor, the next question is that, sir, how do you prioritize management in child presenting with bilious vomiting and severe distensions?
So this is a very important question. This is the crux of the our presentation for these three sessions. So this is surgical emergency until proven otherwise. Immediate priority, emergency, anivani. So assess airway, breathing, oxygen if needed. Then in circulation, intravenous assess, fluid restriction in the form of normal saline, like etc. Correct the shock. Then assess neurological status. Then full abdominal examination we have to do. And simultaneously, patient should be kneel by oral, kneel per oral, nasogastric decompression by the nasogastric tube, electrolyte corrections. We have to correct the electrolytes and the surgical consultation with the pediatric surgeon or the surgeon. So, what are the important differential diagnosis in neonate? Malrotation with volvulus, intestinal atresia, then Hirschsprung disease. We have discussed that failure to pass meconium, that is congenital megacolon. In older children, adhesive obstruction, intersusception, in that intersusception, recurrent jelly stools, and internal hernia. So, what are the red flags? Bilious vomiting, progressive distension, peritonitis, shock, blood in stools. So, clinical pearl is bilious vomiting equals intestinal obstruction until proven otherwise. So, it is an emergency. Fast way to act.
Yes, sir. Thank
So,
you. And the next question is, sir, are there any better alternatives to X-ray for certain cases?
yes, a very good question. For intersusception, we can do this ultrasound, UHG, you can say. In pyloric stenosis, also we can do ultrasound. In appendicitis, also ultrasound. In gallstones, also ultrasound. In volvulus, we have to do upper GI contrast studies, volvulus. And Hirschsprung disease, contrast edema, biopsy is required, rectal biopsy. In constipation, there is no X-rays required. It is a clinical diagnosis. And foreign body में X-ray कर सकते हैं, लेकिन वो opaque होना चाहिए. रेडियोलुसेंट रहा तो वो foreign body नहीं दिखेगा. So, what are the advantages of ultrasound? No radiation, dynamic assessment, bedside availability, and higher sensitivity for many abdominal disorders. So, in modern pediatric practice, ultrasound has replaced abdominal X-ray for many diagnostic dilemmas. Yes.
Thank you so much. And the last question, sir, what I would like to ask before conclude the session, uh, which clinical red flag should prompt to prompt the physician to screen a colic disease even in absence of diarrhea?
So many children with celiac disease do not have diarrhea. Okay, so what are the gastrointestinal red flags? Chronic abdominal pain, recurrent bloating, persistent constipation, recurrent vomiting, unexplained elevated transaminase HGOT or HGPT. Growth red flags, short stature, growth failure, delayed puberty, weight, faltering. And what are the hematological red flags? Iron deficiency anemia, resistant to treatment like iron, and folate deficiency and unexplained anemia. And the bone and dental red flags, recurrent fractures, osteopenia, dental enamel defects, and neurological psychological red flags, headache, irritability, ADHD like symptoms, then ataxia. So what are the high risk groups? Where to screen, in which high group about the celiac disease? Even if patient is asymptomatic, type 1 diabetes, Down syndrome, Turner syndrome, autoimmune thyroid disease, then first degree relative with celiac disease. We already discussed celiac disease. So initial screening test is total IgA and TTG. ये दोनों करना है, शंकर के साथ नंदी, याद रखना है ना, चांद के साथ चांदनी. If IgA deficient, IgG based serology, DGP IgG or TTP IgC. So what is the clinical pearl? Iron deficiency anemia and short stature are among the commonest non-diarrheal presentation of pediatric celiac disease. So this completes the pediatric vomiting. We have completed almost 50 cases in all details. So over the 3 sessions. So
Yes.
thank you. Thank you. Go ahead.
Thank you so much, sir, for completing such a wonderful topic and very deep practical insights from your side on such an important topic on vomiting. On behalf of entire Docplexis team, we really thanks Dr. Ravindra Sonawane for sharing your valuable insights and deep practical experience on pediatric gastroenterology on vomiting chapter. So
Yes. So thank you, Shipa. Then Sushant, all
so your sessions are
Docplexis.
participant for joining us today for your active. Yeah.
Okay,
So
yes.
yeah. Thank you so much, sir. We are looking for many more collaborations and many more events with you for future as well.
Yes. So thank you, Shipa. Thank you, Sushant, all technical team and all Docplexis team and Docplexis honor. And thank you all listeners, pediatricians especially, then the physicians, all undergraduate students, postgraduate students. Thank you very much for giving a huge response. And thank you once again for giving Docplexis, for giving me opportunity. We are looking forward for the next session that will be mainly acute abdomen. We will cover 30 cases in that. So thank you very much.
Thank you, sir.